All right. Recording is on. All right. So today we have our quote of the week. We're going through chapter 15, energy sources in surgery. We do have a Kahoot, and then we're going to wrap it up. Okay. Keep in mind, you guys see the camera on. Make sure that your camera is on. I'll give you guys a couple minutes. I think everyone pretty much has it. Um, let's get started. Our quote of the week. All right. Courage doesn't always roar. Sometimes courage is that quiet voice at the end of the day saying, I will try again tomorrow. And that's by Mary Ann Ratchmer. Now that midterms is behind you, I want you to pause for a moment, okay? Not just to reflect, but to recognize how far you've already come. This quote is a reminder that strength isn't always about being the loudest in the room. It's not about having all the right answers or feeling confident every single day. Sometimes strength is quiet. It's choosing not to quit. It's saying, you know what? Today was tough, but I'll come back tomorrow even stronger. As future STs, you are being trained to stay really kind of steady under pressure, to think critically, to improve each and every single day. Now, the next 6 weeks is going to challenge you, but it's also going to shape you. The final exam is right around the corner, but you have assignments, you have knowledge checks. Every quiz, every effort in between now and then is a chance to just rise. So if you're feeling uncertain, take heart. Your courage doesn't have to be that loud roar. It just has to keep showing up, which is what you're doing. So let's finish this thing strong together. Okay. Now that we have that out of the way, I did want to revisit some of your midterm questions. I am going through because y'all know we did a whole revamp on our questions. And so sometimes technology doesn't convert always correctly. So I am going through, and today I looked at 200 because that was the class we are. And then tomorrow I'm going to look at 210. But if you notice that your grades have been adjusted. I don't know if you have had the opportunity yet, but make sure you go and look. So I am doing that just because we did revamp. And so sometimes technology does its thing. Now, one of the questions that was revamped or readjusted, I wanted to kind of go over. Now, the question asked about responding with a sarcastic tone. Okay. And it's encouraging confidence building as the correct answer. Right. And we know that wasn't correct. So, in practice and alignment with the CST standard, sarcasm is often misunderstood and can disrupt teamwork. So, if you remember that was one of the answers that you did choose, don't stress, it has been adjusted. Now, because of this mismatch, again, credit has been given for both the keyed answer and the answer that reflects correct professional practice. So, if you did for some reason get it the other one, you're not penalized. So I also want to stress that too. So our goal is always to just kind of clarify, respect, and teamwork. Okay. So keep that in mind. There were a couple more questions that I went through and changed, or not changed, but adjusted to what is correct based on the CST and our book. But if you go through and you notice something, let me know as well, because I am only one person and we are a team. So if you notice something else, let me know. Okay. Now, with that, we also have to understand informed consent for the illiterate patient. Imagine you are prepping a patient for surgery and the nurse brings in a consent form and the surgeon explains the procedure. Now, everything is ready until you realize that the patient can't read or write. So, what do we do now? Well, the principle behind an informed consent, it's not enough for the patient just to sign a form, right? For the consent to be valid. The patient must also understand the procedure, know the risks. Let's say in this case, it's for an appendicitis, and agree to it voluntarily. If a patient is illiterate, It doesn't mean that they cannot give consent. It just means that we have to handle it a little bit differently because we still got to protect their rights. So keep that in mind. Now, as we go through our live session, and it's not a long session, I'll just be honest with you guys, it's not that long. I want you to think of these questions from the intro video. Why does Eshkar on the active electrode create a hazard? What does the acronym LASER stand for? And what kind of electrosurgery require a patient return electrode? We're going to cover all of this. And as you're going through, the one thing I can tell you as we get closer to the final is that there are a lot of scenario-based questions, more so in Module 3. You guys got a little bit of it here, but more so in Module 3 and definitely on the CST. So we are vamping that up as well. You'll also notice starting next week, once we get into our like Kahoot and our poll questions and even our Quizlets, I'm going to be kind of mirroring how you're going to actually see the questions coming forward on your final. So we're stepping it up each way. So you have your knowledge checks that have kind of one type of question, and then the quizzes will kind of add on to that. And you saw in the midterm where we really kind of like double down really, and then the final is to kind of bring it all together. So if there's anything again that you're just like, whoa, I see the answer, I see the question, I got to bring it together, let me know. Okay. With that, chapter 15, energy sources in surgery. We've got learning objectives. We have to understand how electricity works in the body during surgery. Did you know that there's certain cases that we can't use our electrosurgery with because what the patient got going on with them? We're going to talk about that tonight. No, we have to understand how it helps cut tissue, stop bleeding, and what equipment we actually use. We're going to compare monopolar and bipolar because they're actually different. And I have an image so that you can see the difference in them and kind of these are these cases that we use it with versus the cases that we don't. And we're going to talk about grounding. We can't just be putting electricity in a patient and not have a way for that loop to be closed. That would cause a lot of charring, and that's not one thing that we need in the operating room. And then we're going to learn about common safety hazards with electrosurgery. And there's some steps that we take as STs to prevent accidents. So let's get into a little bit of introduction. So again, what you see in front of you is our Bovie pencil. This is what we use just like a knife. When you're handing it to a surgeon, you're passing it to them just like a pencil. You see a button here. When you have it in your hand, and this is just a regular pencil, but imagine that it's a Bovie, you're going to give it to the surgeon so that they can use it in position of function. Just like here where they're kind of demonstrating without gloves, they're using it in surgery that way. The buttons are in a way that when they're cutting and coagulating, they don't have to do much. So that's why we hand it to them in position of a function. It doesn't matter if they're left or right, okay? So it cuts, it coagulates. We're going to break those down. The chapter wants you to know about conduction, current, direct current, frequency, impedance, and voltage. Now, we're not electricians, okay? But it's going to be important to be able to differentiate them. Okay, let's start with conduction. Conduction is the process of electricity moving through material, like a wire, or tissue in our case in the operating room. Electricity moves through wires to the surgical instrument or electrodes. So this same pencil, picture it as that Bovie. Let me go back a slide. There is a sterile cord that's attached to these pencils that is going to be connected to a machine. The electrical current is going to go through that wire, and it's going to, and that's how you're going to be able to, the surgeon's going to be able to use the pencil, okay? Now, with the current is what's going through the wire, okay? It's what powers electrical devices, and it is measured in amps. You may see that in this week's quiz. measured in amps. Okay. The current is used to power our instruments for cutting or coagulation. Your direct current, your DC, this is a type of electricity where the flow of electrons moves in one constant direction. So let's say it's only going one way, okay? It's typically used for our batteries, small equipment, but it's not going to be commonly used for our bovie or our electrosurgery. We have alternating current, which is your AC. This is a type where the flow of electrons kind of changes directions, okay? AC is used for most of our electrical equipment, including that electrosurgical pencil. When we talk about frequency, frequency is how many times the direction of electricity changes per second. This is measured in hertz. Higher frequencies have a faster flow of electrons, and it makes sense because they're moving faster, like they're moving in different directions a lot faster. Now, in the operating room, high frequency current, like 500,000 hertz or more, is used in electrosurgery because it can cut or coagulate tissue without causing damage to surrounding areas. So it's not charred around, it doesn't give you that burnt scarring around it. Now, high frequency currents avoids interference with the heart or nervous system, and it reduces the risk of that electrocution or cardiac arrest. With impedance, impedance is the resistance of the flow of electricity through a material, similar to how a narrow pipe resists water flow. So let's say you have a river and you're like, I'm going to put a pipe here to slow it down. Well, there's only so much water that's going to be able to go through the pipe. Okay. Some tissue, like fat, have higher impedance. That means it's more resistant to the current. They're going to be like that pipe. Versus muscle that will be more like the river. You can get through. Okay. Surgeons need to understand how different tissues react to electrical current. And that way it makes it safe when they're using it on patients. The last term that you really want to make sure you just have a good understanding is voltage. Voltage is the force that pushes the current through a conductor. It's measured in volts. It's like the pressure of water moving through the pipes. Okay, so we already have the pipes, and it's how fast it's going. Voltage helps control the amount of current used in electrosurgery. The correct voltage is going to be needed to safely perform tasks like cutting and coagulation. Now, I want you to keep in mind that the human body is very sensitive to low frequency electricity. At high frequencies, like those used in electrosurgery, tissue is going to be able to be cut, it's going to be coagulated or burned without the risk of electrocution or cardiac arrest because the energy is absorbed more by the tissue, and it's not going to interfere with our heart, which again is very important. Okay, so make sure you're going back and just having an idea of, okay, how can I identify the difference between the terms? So again, let's break it down just a little bit more. We're trying to make an incision. Yes, surgeons can make an incision with that bovie pencil, and they often do. Now, a lot of times we're still going to give them the knife first. That's usually going to be one of the first things on your Mayo stand that's loaded. But there are times where you're giving them the bovie pencil to make that cut. Okay. This is often faster than traditional scalpel because if you think about it, with a regular knife, you make a cut, it bleeds. Now you got to figure out how to control the bleeding. But with a bovie, which is what we normally call the ESU pencil, a bovie, you can cut, coagulate, reduce the bleeding, and continue on with the surgery. Now, it also coagulates. When I mention coagulate, I'm talking about stopping the bleeding. It causes the proteins in the blood to actually solidify, and that's what prevents further blood loss. It also destroys or removes diseased tissue. It can be used to target and destroy abnormal tissue like tumors or growth. This is especially useful in treating cancers or other tissues that look just off in surgery. But did you know that it also welds tissues together just like a welder? It can be used to kind of take edges and literally weld them together or make them stick, which is very helpful for joining tissues during surgery, like an organ transplant or certain types of repair. Now, there is a difference. The chapter wants you to know between electrosurgery versus cauterization. And I'm going to break it down so you don't forget it. Now, electrosurgery uses high frequency electrical energy to cut, coagulate, or destroy. We know that, right? This is allowing surgeons to perform those delicate procedures while minimizing damage to the surrounding tissue. Now, tonight I might sound like a broken record, but there's a reason why I'm repeating. Hint, hint. Now, the energy used is going to be very high frequency, okay? Meaning it's not going to cause interference to what? The cardiac function or the nervous system. Cauterization, remember, I told you you're going to memorize this, or remember, not memorize, remember. Cauterization, on the other hand, is the process of applying direct hot heat to stop bleeding. So think about surgery in the past when they would amputate, okay? They didn't have electrosurgery at the time. So what would they do? They would start a fire, grab a piece of metal or something, put it on that fire, get it really hot, put it on the wound to stop the bleeding. That is cauterization. Does that make sense? The difference between cauterization and electrosurgery. Okay. So I kind of wanted to make sure you kind of knew the difference, because a lot of times you may hear it synonymous. It's not. Per the book, electrosurgery, where it's controlled. We have electricity. We're doing it this way versus cauterization. Old time, you've got the barber who used to be the surgeon. He just amputated a leg. He grabbed a sword, maybe, put it on some fire, and slapped it on that wound to stop the bleeding. Okay. Now, there are pieces to this equipment. And so you can kind of see how it works. You have your pencil or your electrosurgical pencil. We have a grounding pad. The grounding pad is going to be on the patient. They're both connected to the machine. Okay. Controls can either be on the pencil or they can be foot controls. Now, the generator itself, okay, this piece over here, it creates that high frequency current used in surgery. This is what sends the current to the active electrode. Whenever you hear me talk about the active electrode, think of the instrument that's going to be used on the patient. Again, for cutting, coagulating, whatever the need is at that time for the patient. Your pencil, in this case, this is going to be the instrument the surgeon uses to deliver that current to the tissue. Again, cuts, coagulates, or even vaporizes the tissue depending on the generator settings. The settings are on the machine. The controls are on the machine. The surgeon's preference card, which is the holy grail for us as STs, is going to let us know the preference of that machine for the instrument that's going to be connected to it. Okay. It could be that they want maybe a 50-50 mix, meaning they want 50 cut, 50 coagulate. They may say 60-40, and it's just going to depend on the surgeon's preference and pretty much where they were trained in what they're comfortable with. This grounding pad, this is what we normally call it, the grounding pad. And there's an image in the chapter that really shows you, it has like the blue gel on it, so make sure you go check that out. This is the safety return current to the generator. That way that patient's not getting electrocuted, okay? It has an adhesive pad on a large, we try to put it on a muscular area, maybe a thigh, depending. Now, if we're doing a leg surgery, you're gonna place it somewhere else, or maybe the opposite appendage, the opposite extremity, Okay, but this is going to complete the circuit and prevent burns. Now, for us, going to break it down really quick. Generator creates and manages current. The pencil delivers the current to the tissue. Your controls, remember they're going to be here, but they're separated here. They're going to adjust the power, the mode. Your Bovie pad or grounding pad, okay, they are synonymous. This is the safety return from the current to the patient to the unit. Our role, sometimes we're setting up, we're checking, we're definitely monitoring all parts for safety and effective use. Now, there are two types that we use, and the chapter wants you to know, and so there's no better way than kind of breaking it down. You have monopolar. Current flows from the active electrode through the patient's body out through that Bovie pad, grounding pad, or the patient return electrode. You may see it all three terms or one term, but it's important to know that when you're talking about the patient return electrode, you're talking about the Bovie pad, also calling it a grounding pad. Okay, the three are synonymous. Now, your Bovie pad, again, is placed on a large muscle area, preferably to safely return current and prevent burns. For our bipolar, this one's a little bit different. Both active and return electrodes are on the same instrument. They're in between, so we do not use grounding pads for the bipolar. Why? Because the electricity isn't actually touching the patient. It's not going through the patient. It's going through the instrument itself, and the current flows only between the two tips. There's no traveling through the body. So we don't tend to have a grounding pad. Now, we may have one in the room in case we need to switch to monopolar, or if we're doing a case where we're using both bipolar and monopolar, then we're going to automatically put a grounding pad for safety of the patient. But if you're using bipolar by yourself, if the surgeon is using it by yourself, there is no need to have that grounding pad or the patient return pad. Okay. Again, why? Because the current is only flowing through the tips. Okay. Does that make sense before we move on? Okay. Again, this is just
I'm
another,
sorry.
go ahead.
Just to make sure that I have it right. So bipolar is no Bovie pad. Bipolar is
Correct.
a Bovie pad, but when you use both of them, you have to use a Bovie pad too, right?
Yes, yes. Yes. Excellent question. Love that. And yes, that's, you guys, make sure you guys heard what she said, because you may get a scenario question that says such and such patient is being set up for a particular case. They have a electrosurgery pencil and, let's say, a bipolar forceps on the field. Does this patient require a grounding pad? The answer is yes, because they are using this Bovie pencil as well as the bipolar. Now, the bipolar is the only one that does not need a grounding pad, but the electrosurgery pencil does. And there's other instruments that are monopolar that you're going to need them as well. Great question. Now, again, I'm a vision person, so I really want you guys to kind of see this in image side by side. And I did grab that grounding pad. So make sure if you want to go see it a little bit larger in the book, this is what the grounding pad looks like. This part right here is what connects to the actual machine. But you can see the difference from cutting, which is high voltage, coagulation, which is low, and you see what it does, and fulguration. Think about destroying those tissues. Okay. Now, when we look at safety, because that's a big one, again, this is straight from the chapter, straight from the book. Another picture. So now you can see it all together. Now, this isn't a Bovie pencil, but again, this is a monopolar instrument, which means we have to have that grounding pad on. This is going to be more for a laparoscopic or a case where we use cameras. Yes, we still have to have some type of electrosurgery instrument to cut and coagulate, even in those type of cases, even more so, because we're not able to kind of get in there with our hands, and our instruments become extensions of our fingers. Okay. So in this is just usually the Maryland grasper that we usually use, and it is monopolar capable, meaning that we can take a monopolar cord and connect it, and they have like a little probe on the back that you connect it to the monopolar instrument, and then it goes to the machine. And this is where all the controls are at. Okay. Now, there are hazards though, and I really wanted to make sure you understood. Electrosurgery lets us cut, cauterize at the same time, but it can interfere with certain implants. As STs, we're the first to spot these risks, and we have to keep the patient safe. So I like images, okay? Pacemaker, you're probably like, okay, remember, we're trying not to interfere with any cardiac rhythm. Pacemakers keep heart rate steady. That electrical current can disrupt or stop it. So most likely we're going to use a bipolar, okay? Because we're not trying to disrupt anything. We have implanted cardiac defibrillators. Now, this restarts the heart during dangerous rhythms. Interference can cause false shocks or failure to shock. We have our deep brain stimulators. Sometimes we're putting these in the operating room. So we're not going to have monopolar. And everyone in the room knows. Well, someone will say, like, especially if we're doing a cochlear, we're doing a cochlear implant, make sure there's no ESUs or bovies in the room. Okay. Now, for deep brain stimulators, these controls symptoms like tremors, and that heat, getting close to that, can damage the electrodes or the settings altogether. We have our spinal cord, and you really can't see, but just know that there is a spinal cord stimulator for this individual, and that blocks pain signals. Now, that energy can cause a malfunction. So now the patient's still getting the pain, and they got the stimulator in the back. Cochlear. I mentioned cochlear implants. That's an ENT case. Okay. This restores hearing. The electrosurgery can actually damage the electronics in the cochlear implant and then make it so that it's no good. We have auditory brain stem implants as well. So you can kind of get why we're very particular when we talk about having different implants in the body, because we want to make sure that if this patient has any of that, and you'll know that in the timeout, and usually that's where we kind of go over everything. You're going to learn that next module. But during the timeout is where we talk about the allergies. We talk about what's going on with the patient. And we talk literally about, okay, we're doing a cochlear implant. The surgeon will usually say, we're not using a Bovie pencil. And most of us are like, okay, we know, but it's still good because you just never know. You might not realize that, oh, this is what we're doing. So our role, we're going to always check the chart for implants before surgery. We're going to alert the team if, oh, hey, did you guys notice that this patient does have a brain stimulator? We're going to have our alternatives. Like I mentioned, we're going to use bipolar when appropriate. Remember that you're just not passing instruments, but we're also the patient's advocate. Okay, so that's the first half. I told you this chapter is not that long. But now we have to understand the difference between capacitive and indirect coupling. We're going to look at our role when it comes to smoke plume. We're going to talk about what that is and why it can be dangerous. And we're going to learn about lasers. Yes, we do use lasers in multiple services in the operating room. We're going to look at the types, and then we're going to understand how we stay safe in the operating room around lasers. So right off the bat, again, got the images for you. We have, starting with capacitive coupling over here. With capacitive coupling, it is when unwanted electrical currents kind of leak through the installation of electrosurgical instruments instead of going through the targeted tissue. So think of it like little sparks kind of coming out, right? It's supposed to stay enclosed, but now it's not. So why does this happen? It's when there's a buildup of electricity, okay? And that buildup discharges through the insulation and it's often around the wires or the electrodes. This can cause burns or injury in areas that it's not intended for that current flow. So, what do we do to prevent it? Well, we tend to use metal cannulas and active electrode monitoring to detect leaks early. So, it wouldn't even come to us. Like, it'll be tested and checked, hopefully. But this is kind of good to know if for some reason you're in the operating room and you're checking and you're like, wait, something's not right. Now, direct coupling is slightly different. So if you look, it kind of tells you like it's going through the insulation, it's kind of peeking out. Now, for direct coupling, okay, the current jumps from the conductive object to another, from an active electrode to a metal instrument without passing through the tissue. Now, how does this happen? Defective insulation or contact between electrode and another metal object, or even placing the electrode inside a conductive metal sheath by mistake. This again can cause unintended burns or tissue damage. So they both cause unintended, but the way that it happens is slightly different. Again, capacitive coupling, it leaks through the insulation. Direct coupling, the current flows directly from one conductive object to another. So one's going straight to, the other one's kind of like spilling out and then getting it. Okay. But why is this important to us? Well, both can cause serious burns or injuries. So we're always going to inspect our insulation. We're always keeping our equipment maintained. And then we're going to monitor our ESU unit during our procedures. Another thing that we are around a lot is surgical smoke plume. Now, before we even get into surgical smoke plume, what do you think surgical smoke plume is? What do you guys think it is? Okay,
Does
it
it
is
cut and
definitely a part of burning skin, but is it just burning skin, do you think?
does it cut and coagulate?
It cuts and coagulates. It's what someone said it smells like hair. It's the toxic smoke. It is produced from Ishkar. Yes, you guys have been reading. I'm loving it. It is toxic smoke produced from Ishkar, kind of like ash. I always think of smoke plume. It's gonna sound really morbid, but you guys about to be STs. You guys actually are STs. We're just going through the motion. Um, you're at a barbecue meat's cooking, and then there's that smoke coming through the top of the barbecue. Kind of sounds crazy, but it's similar. Okay. Now, it might not smell as fresh as that barbecue meat on the grill, but it's kind of the same concept because all of that is going up. Okay. Now, it is created when tissue is burned, it's vaporized or even cauterized. It also contains, besides the fats, besides the toxic smoke, harmful particles, living dead cells, cancer cells, viruses, and bacteria. Now, why? Well, sometimes patients coming in and they may have cancer cells and we're trying to destroy them, right? So that smoke's going to be released. They may come in with a virus, they may have a bacteria. Well, just because we're cutting it, it's not going to destroy it, right? So that goes up into the atmosphere. It can also contain, like you guys have already said, toxic smoke, straight from the book, but hydrogen cyanide, formaldehyde are some of the ones that could potentially be in there. Not to scare you, but it can have infectious disease transmission as well, inhaling the pathogens from the plume. Okay. Breathing in harmful chemicals can cause respiratory issues, headache, long term health problems. Now, for us in the operating room, we have a couple things that we do automatically. It is like second nature. So if you're looking at these two Bovie machines and you're going to Bovie pencils, and so I'm going to start using so you hear what we say in the operating room, okay? But just keep in mind this is the ESU pencil. So you got two Bovies in front of you. You have one Bovie without evacuation system or a inline suction connected, and you have another one with. When I'm in a case and my facility does not have a inline suction type Bovie, I automatically have my suction. And if it's just me and my surgeon, when they're cutting, I got that suction right there. It sucking it up. If you have the inline, then you don't really have to worry about because it does it automatically. So you can kind of see it's not going up, it's going in. Okay. Now, both remove the plume at the source. Another thing that we do is we try to maintain proper room ventilation. We got on our masks, we have on our face shields. Remember, those who have glasses, there's a couple different options for us. I like the masks with the shield, but sometimes I will wear my shield over my glasses. Just depends on how I'm feeling. Now, the chapter wants you to know the smoke evacuation system removes smoke directly at the surgical site at 100 to 150 feet per minute, or 30 to 46 millimeters a minute. It passes smoke through a HEPA filter and absorbers, I should say, trap that hazardous particles and the chemicals. When they're done, filters are biohazardous wastes, and they have to be disposed of per hospital policy. Now, what we do is we just make sure that if we do have a smoke evacuation equipment, it's present, it's set up, and it's working. Because it's one thing to have it in the room and it's not working, right? We also follow safety protocols to protect ourselves as well as our patients. Now, we also deal with lasers in the operating room. Now, the definition of laser, you might see this again. Light amplification by stimulated emission of radiation. Let's see if I can copy this for you guys. There you go. Light amplification by stimulated emission of radiation. Now, how does it work? Okay, so it produces a focused beam of light to cut, coagulate, again to stop the bleeding, or vaporize tissue. Yes, it does the same as electrosurgery. Now, it's very precise. It does reduce bleeding, and it is ideal for delicate work like eye surgery. We use it. We use it in some tumor removals, and derm uses it a lot in skin procedures. Now, dermatologists, yes, they do come to the operating room and utilize space for their nevises and different things that they take off superficial where anesthesia is not needed. Okay. But electricity does not pass through the patient during laser use. I will repeat that. Electricity does not pass through the patient during laser use. So there are laser safety standards, and the chapter talks about ANSI, CDRH, OSHA, and AORN. Make sure you have a good grasp or a way to kind of identify which one protects workers from laser hazards as opposed to which one gives us guidelines. Now, why does this matter for us? Well, we help make sure lasers are used safely in the operating room. We have to follow all the safety standards from the PPE that's worn, applying proper handling procedures. There's laser rules that exist to prevent injury to both us as well as the patient. And because that beam is powerful and can cause serious harm if it's misused. We're going to talk about that later. But how does that work? Now, we have our light right here. The light is energy that travels in waves, okay? And it's made in tiny particles called photons. Laser light is special because it's more focused and powerful than regular light. We have our monochromatic. Monochromatic just means like one color, light of a single wavelength. Laser's light is monochromatic, so it targets tissue very precisely for cutting and stopping bleeding. The chapter also wants you to know about coherency. All the light waves move together in sync. It's like a synchronized swimming team, okay? Staying focused in a tight beam. And so if you notice with synchronized swimmers, they try to stay tight, they try to stay on sync, all one. Now, This makes lasers much more accurate and powerful than ordinary light, which spreads out. When we talk about our laser medium, your solids, your liquids, this is the material inside the laser that creates and then amplifies that beam. Now, gas lasers, and we're going to break these down, they use CO2, common for cutting, coagulating, and surgery. You have solid lasers as well as liquid lasers. Now, I told you I was going to break it down for you. This chart really kind of gives you the laser type, the medium, the light type, common uses, and why it actually matters. Now, we'll start with gas lasers. This uses gas as the light producing medium. Okay, so your examples that you see up there are your CO2 for cutting and coagulating soft tissue, your argon, these are what we use in our ophthalmic procedures or when derm comes in, dermatology for skin treatments. It's powerful, precise, and it's used for delicate work. Our solid lasers, they have a solid crystal or glass. Now they are rare earth metal ions. So you're going to hear Indy YAG a lot because we use YAG in our eyes, again, ophthalmology, dental, and sometimes in some surgical uses. They're durable, they're stable, and they penetrate deep tissue. With our semiconductor, they use gallium. Okay, again, you've probably used one of these and didn't realize it, your laser pointers. And then we do use them for some ophthalmic or eye surgeries, but the one you're most commonly with is your laser surgery or your laser pointers. We have our excimer laser. These are going to be the ones for those who want to go specifically into eyes, LASIKs. Okay, they cut precise without heating. They are ideal for those type of cases. And the last one down there, your solid state, or it says your dry or your dye lasers. They are high efficient, compact, precise beams. Again, derm, some cancer treatments. Okay. Again, I am going to, because I created these, I'm going to go ahead and provide these for you guys as just an additional resource to kind of help you differentiate, the different types of lasers and the uses. So here, pretty much in word form, here kind of like image to bring it down for both types of learners. For me, I like them both ways. So you will get that in that little archive area. It'll be a link to these charts. Okay. Now, with the classifications a little bit differently, they're based on the safety risk associated with their use. We're going to start with class 4 up at the top. This is important because it causes, and I have seen questions or concepts asked on the different classes. Permanent eye damage, if viewed directly or if viewed indirectly by like the reflection and it kind of gets your eye. These lasers can also ignite materials and cause skin burns. Most surgical lasers are class 4 lasers. I will repeat that. Most surgical lasers are class 4 lasers. Now, how would they ask you this on a final? They're not going to come out and say, this class 4 laser, blah, blah, blah. They may say, because keep in mind, most surgical lasers are class 4. You're in a surgical case and a laser is being used. What type of damage could be from directly viewing? Okay. The reason, and that's a great, okay, before I answer, why they won't just come out and say class 4? Is that the question? Okay. So on the CST, we've noticed, and we don't write the CST, so we've noticed on the CST that when they start asking these questions, they want us to think past just what the book says. And so we're trying to align it, but I'm already going to give you guys the hints now so that when you get to it, you're going to be golden. So, and this is just what we've been noticing. So the last couple CSTs that they've been passing, they've been asking a lot of scenario-based questions where that the lasers in the operating room are class 4. That class 4 lasers cause permanent damage, but they want us to bring it together and help you guys to get to it by kind of connecting the dots. So, and that's a great question. And you guys keep asking questions like that because for me, I want to know why too. Like, why aren't they just coming out and saying it? Because they want us to kind of think beyond just what the book says, and then they're bringing in real world. Okay. So in this particular instance, we talk about surgical lasers. Keep in mind, most class 4, they're going to have permanent eye damage. Does that kind of help explain it? Okay. Now, class 3B. So you'll notice that they may also ask how many classifications on this week's quiz. You know, you see 4, but there's 5 because there's 4, 3B, 3A, 2, and 1. I have seen that highly missed because when we automatically think there's class 4, we class 3, but remember there's 3B and 3A. So there's actually 5, not 4. Okay. Now, class 3B causes severe eye injury when viewed again direct. Lasers do not cause injury when the laser beam is kind of diffused, or do not permanently, it's not going to be normally present for a fire hazard. So it's not necessarily going to cause a fire, okay, like class 4. With class 3A, normally do not cause eye injury if viewed, but they present a hazard if viewed with like collecting optics, or if you have some type of fiber optic cable, or you're looking through, like let's say you're doing a laparoscopic case, it could cause damage that way. Okay. With class 2, they emit radiation in the visible range. These lasers do not normally cause harm when viewed briefly. So like you look at it and you're like, okay, you're good. Although they can be hazardous when viewed for like, you're sitting there looking at it straight on for like an hour, that or longer. Okay. Laser pointers. You know, you always tell people don't point that in someone's eye. Okay. Laser pointers. These are going to be class 2. Your class 1, they're not hazardous for continuous viewing. They're considered incapable of producing damage. They don't really have radiation levels. They are exempt from continuous issues, control measures. What type of lasers do you think these are? Just right off the top. You've probably used them, by the way. Yes, laser printers. They do fall into the classification for lasers. So yeah, laser printers are class 1. So again, how many classifications of lasers are there? 5. Yes. Now, what do we do if we're going to do a laser case? Well, there's some key things that we kind of work on. There's going to be a laser safety officer, just so you guys know. Their laser equipment, it's going to be locked. So that's going to prevent unauthorized use when the laser is not in operation. We keep fire extinguishers nearby lasers because they can start fires. Believe it or not, if there's a laser case, you're not automatically going to be able to go into it. They sometimes require, at least at the children's hospital, they require that you kind of work with a preceptor for a couple, even if you've been a tech for a while, just to make sure you're comfortable with all the equipment and what you got to get done. And then we post signs everywhere. We have a sign in the front door where the patient comes in and a sign in the back, so that anyone who's coming in, there's this sign right here and goggles that are going to work with the type of laser that we have. So we have enough for anesthesia, our surgeon assistants, the nurse or circulator, us, patient has their own, and then we have 2 extra on the side on the doors with the sign. Okay. We also use flame resistant drapes if possible. Now, with that, we have some things that we do additional. We use safety goggles. These are the type that we have, and it's going to be based on the laser. Not every laser goggle is going to be for every laser, right? So the type of laser, the goggle will be attached. We place filters on our lenses to block harmful light. The patients have their own shields. We cover shiny surfaces. And again, these laser signs are everywhere on the room. So we're not posting them all down the operating room, but on that particular room. So let's say most of our lasers are done in room 3. We would have one again in the front and in the back. Okay. Now, for our case study, the last thing we have is our case study. Told you this isn't that big. I want you to think about this, okay? During surgery, we're scrubbed in. The surgeon asks us to hold a clamp he just placed over a vessel bundle. He proceeds to buzz the clamp. You suddenly feel a sharp burning pain. So you don't want to drop the instrument because remember you have vessels in your hand, but you're just like, oh, what's going on? Okay. You're holding the hand, clamp starting to like you're feeling the burn. What do you think caused this and what should you do? Remember, you don't want to automatically drop it because you're holding vessels during a procedure. What do you guys think? We're going to inform the surgeon right away. First and foremost, most definitely, yes. Now, the sharp burning pain you felt was caused by an unintended electrical current passing through the clamp and into your hand. Is this most likely um indirect? Could be, right? Inform about the pain, the current? Yes. Now, this can happen if the surgeon is using a monopolar electrocautery and you see that buzzing, and it causes the electrical current to kind of seek an alternative path to that grounding pad, which unfortunately, in this case, is your amazing hand that's holding the clamp. So, some of the causes: improper grounding or insulation. The monopolar cautery requires a grounding pad, right? So, if the grounding pad isn't placed correctly, or if there is an insulation issue, it may not be attached to the skin. It could be kind of like up a little bit. The current can escape through the nearest conductive path because it's trying to find that grounding pad. And if it can't, then it's going to go for the metal clamp that unfortunately you happen to be holding, or in this case, we're happen to be holding. So the clamp you're holding is metallic. So keep that in mind. Provides that direct path for that electricity to kind of do its thing. And your hand is what's feeling it, which isn't ideal. And you guys are actually correct. Communicate immediately. Let the surgeon know to prevent further injury. Okay. Inspect the grounding pad. So you're going to tell your circulator, hey, check the grounding pad to make sure that it is indeed attached to the patient, because my hand just felt electricity. Okay. Sometimes they may just have to readjust it and then you're golden. Make sure your forceps are insulated or clamps whenever possible. That's going to happen when you're doing your case. And then again, report the incident to your supervisor ASAP and follow the protocols for reporting workplace injuries, because you do want to make sure that you receive any necessary medical attention. Taking all of these precautions can help just minimize future risks, right? And ensure both your safety and the patient during similar procedures. Will it be unbearable pain? No. It will be like a little shock. Yeah, it's not going to be unbearable at all because of the amount that's going through. Yes, it can cut or coagulate, but it's kind of like bouncing off. And so, have you ever been next to somebody and you guys brush against each other and you get that electricity? Kind of like that. It's not like painful, but you're just like, oh, stay away, back up. Yeah, I was imagining the type of shock from pulling those gum shot gadgets. That's a good one too. That's a good one. I like that. But yeah, it's not going to be unbearable, but at the same time, you still want to make sure that you're taken care of. Now, I am actually going to share the Kahoot because last week was our midterm, and I kind of want to get you guys a little tiny bit of break, not much, because we're gonna come back next week. Now, keep in mind, I'm gonna start introducing to you guys those scenario-based questions because when it comes to this final, y'all are going to be on it. Okay. Now, with that, if you do notice anything, I'm going to try to go through your 210s midterm, but if there's another question that you notice on this midterm, let me know as soon as possible so that I can kind of run it through, get it corrected, and update or adjust grades as need be. Okay. Because we're all a team. We're in this together and we're trying to just make this better. With that, for those of you that are watching this archive, I have a few questions for you. How do you think the precision of different laser types impacts surgical outcomes? In what ways do you believe the properties of laser light enhance the effectiveness as a tool in surgical settings compared to like regular lights? And considering the unique applications of different laser mediums, how would you decide which laser to use for specific procedures? Let's talk about that in the discussion forum. Now, I know that the midterm is over, but you guys did do really well. There was some in your class that scored A's and one scored the highest, and I kind of reached out already, but I am really proud of you guys. Let's keep this momentum going. We've got 6 weeks. I am here for you guys. So again, I don't care what question you have. There are no dumb questions because this is, you don't know what you don't know, right? So we are here to figure it out together. Okay. We talked a lot about energy sources in surgery. We looked at lasers. We looked at what we do when we're getting ready to use lasers. The quote of the week: courage doesn't always roar. Sometimes courage is quiet. And at the end of the day, saying, I will try again tomorrow. What questions do you have for me? Any questions? All right, y'all. I look forward to seeing everyone who can attend tomorrow's live session. Good night, everybody.